Endometrial endometrioid carcinoma may show a variety of patterns of invasion into the myometrium. In the conventional pattern, architecturally complex glandular structures, with or without areas of solid growth depending on tumor grade, infiltrate beyond the confines of the endomyometrial junction. A distinctive type of myometrial invasion, seen especially in low-grade endometrioid carcinomas, FIGO grades 1 or 2, is the MELF pattern. I know someone had a lot of fun naming this one, but MELF consists of microcystic, elongated, and fragmented glands lined by cuboidal or attenuated flattened neoplastic epithelium, usually with conspicuous eosinophilic cytoplasm and sometimes with a histiocytoid morphology, set in an inflamed, prominent fibromyxoid stroma, which is usually visible from low power and constitutes a clue in identifying this particular pattern of myometrial invasion. Now, here's what I wanted to show you. This is an example. This is a classic low-grade endometrioid carcinoma in a uterine curettage specimen, showing architecturally complex and frequently fused neoplastic glands lined by epithelium resembling proliferative type endometrial stroma. Other areas of the specimen show intact myometrial fragments, some of which are infiltrated by these frequently elongated, partially cystic, and fragmented neoplastic glands, with a prominent associated fibromyxoid stroma, which is visible from this power. This gland has an elongated contour. It is lined by cuboidal cells, has some intraepithelial neutrophils down here, and is surrounded by an inflamed and striking fibromyxoid stroma. This one here has intraluminal neutrophils, is lined by somewhat attenuated epithelium with conspicuous eosinophilic cytoplasm. Notice again the fibromyxoid stroma surrounding the gland. The glands are fragmented and the intraluminal neutrophils spill into the surrounding fibromyxoid stroma. And some have a prominent histiocytoid morphology, meaning the tumor cells resemble, in this case at least, foamy histiocytes. In the image on the right-hand side of the screen, we have all the characteristic features of the MELF pattern. We have microcystic, elongated, and fragmented glands lined by cuboidal to flattened, attenuated epithelium with conspicuous eosinophilic cytoplasm. Some of them have this histiocytoid morphology, and everything is surrounded by this prominent fibromyxoid stroma with associated acute inflammation. So why is it important to recognize MELF? The literature on the prognostic significance of the presence of MELF alone is conflicting, and I'm not going to go into that now. But studies have shown that the neoplastic cells of MELF show loss or reduced expression of cell-to-cell adhesion molecules, such as E-cadherin, which suggests an epithelial mesenchymal transition. The morphological correlate of this is the characteristic fragmentation of MELF glands, sometimes leading to infiltration in the form of small cell clusters or even single cells. And you see how this can lead to underestimation of the true depth of myometrial invasion, especially in borderline cases where you have to decide whether it's more or less than 50%. This then can lead to understaging and undertreatment of the patient. So MELF is known to be associated with deep myometrial invasion. Another important reason to recognize and report MELF is because of its reported association with a higher rate of lymphovascular space invasion and lymph node metastasis. So reporting MELF is especially relevant in scenarios like that of the case I just showed you because of the fact that at least some patients with grade 1 endometrioid carcinoma of the uterus might not receive concomitant lymphadenectomy after a biopsy diagnosis. A pitfall to remember is that MELF sometimes results in subtle, so-called occult lymph node metastases with no glandular structures but only the histiocytoid neoplastic cells I just shown you earlier, mimicking the normal sinus histiocytes of the lymph node. In these cases, ancillary methods such as staining with keratins may help in solving the issue. And if you look at the image on the slide, this is from a beautiful study by Dr. Jolene Price and colleagues published in 2017 in the American Journal of Surgical Pathology regarding MELF and its association with lymphovascular space invasion and lymph node metastasis. You can see what I mean by this sort of sinus histiocyte-like pattern of metastasis. Even more important, though, is to avoid confusing MELF for true lymphovascular space invasion. The flattened cells of MELF microcystic glands are good mimickers of vascular endothelium. So again, resorting to IHC studies such as potoplanin or D240 may be of use to differentiate between the two. And lastly, some studies have reported a higher rate of cervical stroma invasion in MELF, so a more careful assessment for its presence in cases with MELF might be warranted. And this is a picture of another area of the same specimen showing an intact fragment of cervical stroma with endocervical glands and infiltration of the cervical stroma by the neoplastic endometrial glands.